I'm going to go over a few things about COVID pathology and then how it is similar or different to other interstitial lung diseases. Because to just talk about, I do a lot of interstitial lung disease by itself, I don't think is as important as trying to understand why are these patients getting sick, why are their lungs so affected, and how does it damage the lung, and then how is that similar to or different than other injuries to the lung itself. So we'll talk about that. Okay. So the old morgue, a lot for us, our experience really started out in the morgue. If you remember, all of you are too young to remember. Who knows what this is a reference to? Which movie? Yeah, The Fugitive. The Fugitive was filmed in our morgue. When they say that they're in County General, God knows where, when Harrison Ford came running and he was there. So anyway. So that was the background. We actually have modernized since then. This was a couple of years ago, just as COVID hit, we started a new morgue. And so now the guidelines were you had to gown up. At that time, we didn't know. Actually, even today, they still have to gown up and have a team. They wouldn't allow anybody over 60 to do autopsies. So I personally haven't done any of them because that disqualified me because of the risk factors. However, I've looked at all the lungs and hearts and multiple sections from it. So there was a group of a couple of pathologists, my fellow, the technician, and they would gown up and they had a whole process set up of where people will stand, how are you going to eviscerate, where are you going to put the organs. They had to be fixed for 72 hours before doing it. Everything was under negative pressure. Nobody could come in and out while the autopsy was going on. They had a huge protocol of how to section. So we have these tons of sections. If anybody is interested in doing any research, the materials are available. And we have been looking at not just the lung, but heart, kidney, bone marrow. We have nasal biopsies. Initially, it's 6, but we have many more now. Muscles, endocrines, everything. Initially, we were not taking the brain, but now we have a system for how to take the brain out. So we have those also now. So to date, we've done 42 COVID positive cases. And I'm going to go into detail only of the first 16 because I think they were very instructional for us. But when you analyze all the data, the findings have not really changed much. So it is true that a lot of people who have died are older. They have comorbidities, and a lot of them are minorities. As you can see, 69% of those were African American, Hispanic, and then very few Caucasians. That is part of it is because where University of Chicago is located, it is in the south side of Chicago. If you kind of look at the map, that is predominantly black. Our patients are at least 40% black, although, or more. And we serve a lot of underserved, underprivileged people because we have a very large outreach program in which we take people in with no insurance and we try and get them government aid and service. So there is a huge 60% of our population is thought to be the underserved population. Only 40% are privately insured, the rest are not. So we get a lot of people who actually are not in a position to take good care of their health, and they tend to have lots of comorbidities. They tend to come very late to the hospital. They use the ER as their primary care for some times, and so initially our mortality was really high until people learned how to manage them. And I think after the first few months, the U of C mortality actually went down tremendously. We have a very good intensive care system, and the pulmonologists figured out that putting people on high pressure ventilators was not a good idea. It was making their lungs worse, and they came up with like this helmet thing that would give them pressure and oxygen. So things improved a lot over time. But initially, we really had high, like anybody else, high mortality. So the people who died. So now these are the statistics of the people who've died, not of the people who've obviously recovered in the beginning. So as you can see, they were dying pretty early, within 2 weeks of admission, the majority, although there were a few long-term survivors even then. And a majority did require ventilation. A lot of our patients were older and they all had comorbidities. And the comorbidities are listed here. They were, overall, if you look at the US statistics, they say 75% of the patients are obese. It is a huge, huge problem there that people who are, I mean, they also have other issues, not just obesity, but obesity is a huge risk factor for poor outcomes in COVID. Anyway, some had medications at that time. Remdesivir had only just started being used. As you can see, hydroxychloroquine we don't use anymore. There are other medications now. Importantly, 88% were anticoagulated. And we'll talk about that a little bit. They got heparin and they had, now we think that the plasma doesn't really help much, except in very select circumstances. So even in this course of 2 years, we have learned so much about the disease process that things have changed, but that's how it was. And they still get a lot of antibiotics because secondary infections are really important and common. So the two patients that had received no therapy at all were very short. They pretty much died within on arrival at the ER and soon after. So they all had pre-mortem cultures, and they grew either several bacteria or none. But overall, about a third of them had bacterial secondary infection that was critical in this group. The D-dimers, also you can see that several of them have high D-dimers, and thus the coagulation cascade had been activated. So looking at now the pathology of what we saw in these patients, the lungs were heavy and they were almost always involved. There was not a single patient that didn't have any finding in the lungs. They were all either consolidated or they had hemorrhage or had gross thrombi that we saw. So looking at them, when you look at the grossly, basically you couldn't tell them any different from any other infection. They are heavy hemorrhagic lungs, and microscopically I only want to emphasize like 3 different points. The first one is it depends on when you are looking at the lung. Is it early in the disease? Is it in the midpoint? Are you looking at late phase of the disease? So your pathologic findings will depend on how long the patient has been sick. The first few days, we saw in a majority of them 75% diffuse alveolar damage, as evidenced here by hyaline membranes. And even here, you might start seeing some fibroblasts growing over it. So acute injury, more common in the early phases, but we can also see it later. The second finding was there were thrombi in about 2/3 of the patients, and we continue to see those despite the anticoagulation, the treatment. So people do have thrombi, but they can vary in size. It wasn't massive pulmonary embolism that will kill you, but smaller thrombi in different areas. And then the third main finding was superimposed pneumonia. So a lot of them had bacterial infection on top of it. So, I don't know if you've heard that story, but the patient comes in, they start to get better, and then they again get worse. That worse second slope is because of bacterial superinfection in that. So very important to recognize that and treat it accordingly because they were bacterial. So hemorrhagic infarctions in a subset. So now what about COVID itself? So how did we learn to diagnose that this was due to COVID? One of the things we saw, the diffuse alveolar damage doesn't tell you anything. All it tells you is that there's been an infection and this is the response. Is as we started looking around at these sections, you notice, so who will tell me what is unusual about these pneumocytes? Can you see anything that looks different than what you would normally see in a pneumocyte? Yeah, they do have prominent nucleoli because they are all proliferating. So the type 1 pneumocytes are the cells that the virus infects and they die. They get replaced by type 2 pneumocytes. They had very prominent nucleoli in many of them. And then they also had abundant cytoplasm. And as we look closer, see how sort of vacuolated and foamy this cytoplasm is. These are not macrophages. These are the pneumocytes. If you do a keratin stain, these are pneumocytes. So the virus is So that's what we thought, that the virus is in here. So then how are we going to find it? If we look at it, overall, we found over time, this is what I was trying to tell you. Early on, there was more DAD. Then with time, you start seeing a little bit more fibrosis. And we saw infarctions pretty much over at any period. Whenever it occurred, we did. But remember, this autopsy series was over a short period of time. So at the end, I'm going to show you some explanted lungs, which are a different story, because the patients underwent transplant 4, 8, 12 months later. So the findings are a little bit different. But other things, other than the lung, so the lung we said is the most key findings. But other than that, we found that the lymph nodes draining those areas had lymphoid depletion. They got activated, or they were the areas that they were draining. They had some serum, funny looking pools in there. But when you look, there was this starry sky appearance, and they looked sort of, there was some activation of some lymphocytes and activated immunoblasts, but overall more of a lymphoid depletion. We looked very carefully at every organ system. Everything that's been described. I did not find a single case of myocarditis in this subgroup. Of now up until 42, I'm now telling you overall in all our autopsied patients, I have not found anything significant that's not related to an underlying disease in any of the organ systems. So COVID really infects the lungs. And that's where all the morbidity is. So we decided to look at these patients and compare them to influenza, because we have blocks going back to 1912 or 11 when the hospital opened. Our university never threw out anything. So the fellow that I had a picture of, he was very enterprising in it. We actually started out with first looking at just influenza cases that had been autopsied in our hospital before COVID. So we went to the 3 years before COVID hit. So it's from 16 to 19, or 16 to 18. And he picked some cases to compare them to. So we looked at the pathology, and the take-home message for that is that there is no difference. When you look at a case, you can't tell what it is. It's just a viral infection. It's the same. You have those few lymphocytes and plasma cells in the interstitium. You have the DAD, you have thrombi. So all of this talk that there was that, it causes coagulation and it's no different than any other viral infection that's causing severe disease and death. So that was the summary of comparing it to the flu patients. So we picked a case, it was 15 to 18. Age, they were a little bit younger. Remember, we still serve an underserved population. So they were all African American, just because of where we are and what we do. And these are only 6 patients. So it was not really as good a comparison as having the same number of patients. But they also have, 2/3 of them had concurrent medical conditions. They were in the hospital a little bit shorter, and they also needed mechanical ventilation. They did have superimposed bacterial infections, and they also had D-dimer elevation in the patients that had been tested for it. So the coagulopathy occurs not just in COVID, but other things as well, is what we said. One patient who did not have a D-dimer tested was treated clinically for thromboembolism. So and 1/3 of them had evidence of thrombosis at autopsy. So that was one of the key findings that we think contributed to the literature from our program, was that COVID infection is similar to other viral infections. It's not unique in that sense. And here are examples of the influenza cases, the similar things. There is a fibrinous exudate, you have some hemorrhage, there are superimposed infection, you get infarct, you get thrombi, same things. So now if we have a case, how are we going to find out what it is due to? We developed the system. And remember now, 2 years ago when it first hit, there were no ways of doing it. So the challenge is, so we wanted to start immunohistochemistry as well as in situ hybridization for it. And so what would we use for a positive? So at any time that you want to start a test, you have to think about what positive control are you going to use? what are you going to compare it to? So the other thing we realized was that just because the patient had been positive, by the time they died, it doesn't mean that they would have the virus in the lungs. So, and then where was the virus? At that time, we didn't even know that it was infecting type 2 pneumocytes in the very early days. Is it diffuse or patchy? Is there one target cell or multiple targets? People were talking about endothelial cells being infected, heart being infected, brain being infected. And so how are we going to then look for those? What is the background? What are other stainings? Does it cross-react with it? So all of that had to be worked through. And so we looked at, and then how stable was the virus in these post. Remember, these were fixed 72 hours. Many of the patients had been dead for a while. Anyway. So what we started, we did purchase, as soon as the antibodies were available, we purchased multiple antibodies. We did get an amazingly good positive control from a tissue culture, a cell culture that a researcher had developed. And we used that, and I'll show you all that. This is how it looks. So it was a cell suspension that we had made into a block. So cytologic specimens make for really good IHC controls because they are fixed immediately, and especially research tissues. And then it's under your control how you're doing it. So we were very happy with it. So our monoclonal antibody worked really well, and the in situ hybridization worked very well in it. So that was our positive. But what we found in practice was that there was a lot of non-specific staining. Anywhere there was inflammation or activated endothelial cells, things would stain non-specifically. Not everything. How do we know what is non-specific and what is really virus? So what we did was we compared the IHC blinded to the in situ hybridization, and then we dug tissue out of the paraffin block to get electron microscopy blocks. If you used just tissue blindly from the autopsy and submitted for EM, it didn't work because you got, EM blocks are tiny. How many sections are you going to take? What we really realized was that it was infecting only the pneumocytes. And you can appreciate here a very clean case where the pneumocytes are, and then we figured out the dilution was positive. And those foamy sort of type 2 reactive pneumocytes that I was showing you earlier, which are lined up here, are the cells that are lighting up on IHC. There was non-specific staining for macrophages, and you had to be careful for that. And how do we know it's non-specific? Because on EM, we found no particles in the macrophages, only in the pneumocytes. And I'll show you those too. So here are those row of reactive pneumocytes, but not every pneumocyte that looked like that had the virus. So here, only a few that have been shed have the virus. The rest of them that are lining up here are not positive. So similarly, you start thinking, well, here is a cluster that has desquamated into the alveolar wall. Here's the alveolus. The background looks like there's not much inflammation, and then yet you get some positivity. So we had to counter stain. We did concurrent staining with keratin to make sure that there were pneumocytes. We dug out the tissue, and then and you also have to realize that not every patient was positive for COVID. So even though, which we didn't know, and actually even now, a lot of people don't realize it, that even though you are PCR positive, doesn't mean that you are infected anymore. You can still have viral, material in there that the PCR will pick up because it's overly sensitive, and you're not transmitting the virus. Same thing. So we would do nasal swabs on all the autopsy patients to confirm, and then all of them were positive still. So when they were dying, you could still do the PCR. We were not doing antigen testing on them at the time. And then we found that many of them, you could not find a virus in the lung. So the damage had already been done. So we did get false. So we double-blind. We rotated the slides amongst the senior pathologists as well as of the fellow. Only the fellow knew, and other fellows. So to see that how are we going to rate it? If you didn't know who the patient was, we took the flu patients, and we had other patients who had DAD. If you couldn't tell by morphology what it was really difficult to figure out what is positive or not. Some we did, but some we didn't. So what were the problems? The problems were that the background exudates and inflammatory material, bacterial colonies even stained positive. So there was a lot of background staining you had to be careful about. And then we had to figure out what dilution, how are you going to do it? You have to take multiple blocks. And eventually, we sort of got better with it. And now we know how to interpret things. So the moral of the story is that when something new comes around and you're figuring things out, you have to be careful. There are many established methods of how to do things. You do have to follow them and to have good controls. I think the most important thing was having a good control and then figuring out what is false negative and false positive. Okay. But and we also knew that there were a lot of super infections. So this would be, was okay. The in situ hybridization actually was better than IHC. But eventually, now we are at a stage when we know what it is. We start with the IHC if you want to know whether the stain is positive or whether the patient is positive or not, if needed. But, the nasal test is so sensitive. We know who's coming in with COVID now. It's not, everybody gets screened. Everybody who's admitted to the hospital has a COVID screen. Every patient who has a procedure gets a COVID test first. So we kind of know what it is. All right, so correlating it to electron microscopy. Even that turned out not to be so easy. It's not as simple as saying, okay, we'll see viral particles, so that's it. Because the descriptions of the virus were published by the CDC as to how it looks on EM. But in tissue, it was very difficult. And it was difficult, first of all, because this is post-mortem. But also, there are many cellular components that resemble virions. As any of you who have done electron microscopy will know that the organelles can swell up, especially post-mortem, and they can look very similar. So, and then sampling was really a problem. So we really had to get a gold-labeled antibodies or an ISH probe to then correlate. This is the area. So we would do the in situ hybridization. We would dig out the same area. It was very tedious. Anyway, eventually we were able to find, so this is the CDC picture, which somebody has nicely colored the viral particles blue. They are not blue. This is just a coloration. Actually, for this lab, that's very appropriate. It's blue. Okay. But so we dug out these pneumocytes and processed them and then found particles. You can see them here. So as you can see, they look like organelles. They're not, you have to be very strict about the size, the dots that are supposed to be in them, and these, I don't even know how to exactly describe them, but these are the nucleocapsids that when they are cut across, that's how the virus looks. So not straightforward. And there were a lot of artifacts, and they are listed here that you can see that you can see that here. If you didn't know that this is not virus, you would think, oh, these are viral particles, and they are not. These are all other things. So they don't recommend using EM as your diagnostic tool, bottom line. So what is the best tool for diagnosis? If you don't know, I would say in situ hybridization turned out to be the best. And then we have learned how to do IHC also, if you have it. So that was our conclusion, basically. And I've already talked about all the cross positives, and I do want to spend some time talking about interstitial lung disease. And these are all the things that are listed. And you'll have the PowerPoint to go through afterwards. All right, so that is about what I wanted to say about the presentation of acute COVID, how it looked, how we diagnosed it. And the take-home message is that it's similar to other viruses. Superimposed infection is a big deal. Acutely, we saw a lot of hyaline membranes and thrombosis and hemorrhage. And then now I'm going to talk about what happens subsequently. This, by the way, is Chicago during the pandemic. And normally, this is one of the focal points of where everybody gathers. It's a great tourist attraction called the Bean. And normally, there are tons of people everywhere because there's a reflection, and this is tall enough for I think maybe about 200 people can get under it. It's a huge thing. But for COVID, as you can see, there is a line here. They would not let people collect. That's the reflection of the people that are out here. And so one of the things I asked when I took this picture and I showed it to my medical students is, how do you get a photograph with nobody under the bean? Because just never happens. There's always people under the bean. So the response is, you have to really look carefully as to what is going on. I mean, there are people here, they're just far away. So pathology is observation as well. And you only see what you know. which is, I've always said that. But then when you are faced with a disease that you really don't know much about, you have to pay attention and learn and be able to then teach others what you've learned and discuss it. And, so COVID has been its own tragedy and stuff, but we really did learn a lot. So recently what happened was, I got a case sent to me from the outside saying that this was a 44-year-old and they did a lung wedge biopsy. This patient had a recent, quote unquote, recent COVID diagnosis, and I didn't know anything much, but there were bilateral opacifications, worse at lung bases. And what they wanted to know was, there is more of a story, this is how the history first came to us. And you look at this wedge biopsy. So from all that I've shown you, you would know that, there is no way of making a specific diagnosis of COVID unless you actually do a stain. And also this turned out to be about 2 months ago that the patient had COVID. So now the question is, the interstitium here is widened. The pneumocytes do look kind of reactive, but do you think they look like the pneumocytes that I showed you of the, right? No, you can already tell that it looks different. So now the challenge is to describe it and to decide, what does this patient have? Because the treatment is totally different. Does the patient have an underlying interstitial lung disease? So what we were going to do, so this patient did have a history of connective tissue disease. And with this infiltrate, the main differential was your COVID fibrosis versus a CTD, connective tissue disease related interstitial lung disease, such as NSIP. So how am I going to then decide what am I going to do? So first thing, anytime that you have a biopsy that you're not sure what, and this is true for everything in pathology that we do as a histopathologist, is you really need the clinical setting. The clinicians and the surgeons may think, they'll send you a specimen and you will give them an answer. That's not how pathology really works. In some cases, yes, but not when it is a sort of a difficult question like that. You do need to know the clinical context, and part of the strength of our training is, and the intellectual component of pathology is, that we know how to put the clinical picture together and make a diagnosis based on what we are seeing on the slide. So she did have SLE in the past. The COVID was 2 to 3 months ago. And then we knew that it was a mild case. So remember, patients, by now we know that patients who are fully vaccinated and then get COVID don't get long COVID. They are much lower risk of long COVID. So just this clinical setting makes you think, this is likely to be due to her connective tissue disease. And then we have a multidisciplinary conference. All of this gets reviewed. They looked at the CT. They said the patient does have currently positive serology, and the CT was consistent with it. So remember, COVID affects all the lobes, whereas interstitial lung disease has a pattern. If it is idiopathic pulmonary fibrosis, it's more lower lobe. Connective tissue disease is also more lower lobe. If it's hypersensitive pneumonitis, it's more upper lobe. So there is a difference in distribution which you don't see. So clinically, already you can appreciate that this is going to be more likely to be a connective tissue disease. So that's what I thought it was. So your line diagnosis can be descriptive because you are never 100% sure. This is our judgment as to how we call it. So it is an NSIP pattern, as you correctly identified it. And then I did a comment and said, I think that this is more compatible with CTD-ILD than that. So this case got me really started on thinking, how can we compare long COVID with that? So I was very fortunate. I have a great fellow now. And so what she's doing for her research during my year is looking at all our long COVIDs and that we have pathology for, and comparing them to, so we have some of the autopsies, but we have explants as well as biopsies, and comparing them to we pulled out about 100 ILD cases and is doing a head-to-head comparison and did a presentation on it already. So the things to remember, when you're thinking about COVID, you need to know how it progresses from acute, and I already showed you that was hyaline membrane. And then how does it become fibrosis? I'm going to show you of that. I'm going to briefly review some of the ILD patients, and then especially the connective tissue disease, and then I'm going to talk to you how to differentiate them if you didn't know that. All right. So how does COVID progress? So this was our initial one that I was telling you about, that we did it to, not only did he compare it to the flu that was from 3 years before, my fellow then dug out archival material from the 1918 flu pandemic and compared the pathology to it. It's amazing to have, all things. I always used to think, why do we keep all of these things? But anyway, there is a reason for it. So you can look at that reference from him as well. All right. So as COVID progresses, it starts out with little patchy infiltrates. Those are the areas where the pneumocytes have first gotten infected, and then they progress. How do we know that it progresses? There are now several publications that are out there that are documenting that. And here is they did only biopsies, and I got to review. This paper came out very early, and one of them is a faculty member, I believe, I forget which one it is, anyway. So they did only biopsies. And this is what they were showing, that you got, the first thing you see in fibrosis are these areas of organizing pneumonia. So the exudate that it is, but that happens in every exudative thing. So now, from DAD, how does it progress to true fibrosis? So having studied all the cytokines that are released, there is now good literature out there that the pro-fibrotic cytokines are being released in COVID as well as in other infections. And so there is how the lung injury progresses. There is this publication that very nicely describes they can either develop fibrosis or not develop fibrosis. So something in each one of us, as they say, every disease is genetic. We don't think of it that way, but our response to disease, the fact that you can take a whole room full and infect us with COVID, not all of us are going to die of it, right? Maybe one might because of whatever reason. Some might get very sick, some will get a little bit sick, some will not get sick at all, will be asymptomatic, some may not even turn positive. So there is something in our makeup that either makes us susceptible to an infection, makes us susceptible to how severe the disease is, and then makes us susceptible to developing fibrosis, because not everybody develops fibrosis either. They may be equally sick. You can take 10 patients that are equally sick, and only maybe one will develop true lung fibrosis. So we don't understand the genetic basis of disease yet, but as time goes on, we are doing more of it. So what did we find? First, that the fibrosis that develops in COVID is NSIP like I showed you, and that there are no fibroblastic foci and no honeycombing that's been described. And that really was very helpful feature, because remember, usual interstitial pneumonia and idiopathic pulmonary fibrosis is characterized by fibroblastic foci and honeycombing. So we don't see that. And then thrombi and infarcts are common in any lung disease. You can see them in interstitial lung disease as well. And this is, I feel like, something that I have noticed, is that when you look at a section like here in a patient with COVID, when you compare it to other interstitial lung diseases, the air spaces seem compressed down, that the fibrosis is actually, the whole lung volume doesn't increase at all. It rather shrinks, and the alveolar spaces look small, and there's a very uniform diffuse fibrosis. That's about the only thing I can tell that's different about it. Here is an explant. Oh, it looks a little overexposed. Sorry about that. They do develop secondary pulmonary hypertensive changes like any other interstitial lung disease. And let me see if there's a better one. They do get areas of infarcts in these explants, and they can have some inflammatory infiltrates, not that many usually, but not lymphoid follicles is what I've found. And did this die? This died. Okay, we can go down arrow? No, Everything is stuck. Okay. Is this still working? Okay. Yeah. All right. So, what is the significance of this pulmonary fibrosis? You can look at those publications if it is, but they think that radiologically, up to half of hospitalized patients have some residual fibrosis. So it's becoming more of an important long-term correlate. And then this is how it looks. They do have lots of fibrosis. I mean, I'm not a radiologist. It can be a little bit. In this particular paper said more lower lobe and periphery and apical sparing, but I am not sure that when I look at these explanted lungs, I'm going to show you how they look coming up. To just set your eye as to the comparison between what I've showed you so far in interstitial fibrosis, UIP, you have to remember that it has areas of perfectly normal, relatively normal looking lung and abnormal lung. You do get these fibroblastic foci and honeycombing, and that macrophages are common. And so this is to set your eye to what we have already looked at. The air spaces, I think much of them are irregularly enlarged, and that is a key finding in UIP. You should be able to recognize fibroblastic foci. There are reactive pneumocytes, some maybe mild pulmonary hypertension, but generally there is both interstitial fibrosis and replacement fibrosis in UIP. On CT, the way the radiologists describe it actually, if you have the right clinical setting and the right CT findings, a majority of these patients don't even need a biopsy. So I'm actually seeing less biopsies now for interstitial lung disease because the CT findings and the correlate have become really good. So the biopsy that I do see are complicated patients in which they have either a complicated history or a finding that's not classic. So it becomes more of a diagnostic challenge. And so UIP has fibroblastic foci and honeycombing. NSIP is relatively uniform, but it can be patchy, obviously. And then we do subclassify it as cellular fibrotic. And you can see NSIP pattern in UIP. So the concept is that patients who have both UIP and NSIP are more likely to have a connective tissue disease as an underlying factor. So if you remember that, so two things we've talked about. UIP varies in time and intensity. NSIP is relatively more uniform. And if both are present, you have to think connective tissue disease, like the patient that we had the biopsy on, but not always. So here, if I showed you just this, would you vote in favor of connective tissue disease or COVID? Yes, and why? Right, they are a little bit more enlarged, irregular spaces. I don't think that that's 100%, but that's what I have noticed so far. I still have to publish it. As soon as it does, maybe then we can talk about it next time and see. But that's how I feel like with these sort of very large irregular spaces, it's more likely. So how would you then make a diagnosis? Yeah, the history. First of all, you need to know when was this done. This case that I'm showing you is actually from like 5 years ago when there was no. So that helps. But in this day and age, history you would need to know. And then if it was kind of mixed, things can happen, maybe it is not. What else would you choose? What ancillary technique would you choose? Yeah, ish or I'd see if you had it. So, now, just since organizing pneumonia is everywhere, and a lot of patients will have organizing pneumonia, you do need to be familiar with what Masson bodies looks like. And that's, starting from Robbins, you can see it everywhere. We describe it really well. They are within the alveoli. And they can have, the one thing that you should remember is granulation tissue-like, because it's really, Masson bodies are nothing but granulation tissue organizing that fibrinous exudate in the alveoli. So when the fibroblasts grow into it, since there's already fibrin there, and some maybe RBCs, you will get some hemosiderin, you'll get blood vessels in it. And if you see those, it's not a fibroblastic focus. Because a fibroblastic focus is an abnormal proliferation of fibroblasts alone. And only the fibroblasts are sort of proliferating in that area under the epithelium. If you see anything else in it, it's going to be a Misson body. So that kind of, when you're diagnostically looking at it, that's what it is. And all interstitial lung disease can have organizing pneumonia because, the mucociliary system is disrupted. There is abnormal lung architecture. So there is more chances of some infection, even low-grade infections. And they will have fibrinous exudates and they will get organized. So organizing pneumonia is common. All right. So that was just an overview of what is UIP, what is NSIP, and what is organizing pneumonia. What is now specific for connective tissue disease? Only a few things. Obviously, the history is very important. There's a lot of overlap between connective tissue disease related and idiopathic. However, this pattern of having UIP plus NSIP is very suspicious for connective tissue disease. And then we found that dense lymphoplasmacytic infiltrates with lymphoid follicles are more suggestive of it. So here is a patient. This is also an explanted lung. In some area, this is a UIP pattern, and other areas, there's an NSIP pattern. So you would think connective tissue disease. And it is actually very common. I'm not sure that people biopsy lungs here that easily. You probably don't see that. But rheumatoid arthritis is very common here. And I think those patients, a percentage, do develop interstitial lung disease. So why am I focusing on interstitial lung disease? Because there is a treatment now, right? There is a drug, there are two drugs that are really good at it, that are anti-fibrogenic. And they've been using them to good success in patients with idiopathic pulmonary fibrosis. It can slow the progression. Otherwise, a diagnosis of idiopathic fibrosis was a death sentence. They died in 3 to 5 years. It was like as bad as having a malignancy. They were dying. Now they can live much longer, 8, 10, 12 years. The drugs have been around a while. What we are now starting to do is seeing if those drugs would be effective in other conditions. Actually, my cousin's daughter is a pulmonologist here in Lahore. And I was talking to her yesterday, and she says that they are arbitrarily using anti-fibrogenic treatment in their long COVID patients. Wow, now that is an interesting concept, because we are just starting to do that there, thinking, will that happen or not? And here she is, already has thought of it and has started using it. Doesn't have a study yet to base it on, but what are you going to do when you have a patient you have to treat? You want to try everything. So not only in idiopathic pulmonary fibrosis, but other fibroses like chronic hypersensitive pneumonia. So people are starting to use those drugs in other settings as well. And so the question would be, how effective will it be in preventing COVID fibrosis? So my thinking is, by the time I see these explants, that fibrosis is well established. If they are unable to breathe, you giving them antifibrogenic then when they are 6-8 months out and are difficulty breathing, you're not going to reverse it. Those drugs only stop the fibrosis. So you have to give it early. So that means then they have to come up with a scoring system as to which patients are likely to progress to fibrosis. Because remember, COVID fibrosis, as far as we know, is not one of those progressive stuttering diseases. Once you've got the fibrosis, there's one insult and your lung function goes down. And that's where it's going to stay. Whereas in interstitial lung disease, there are exacerbations. The lung function starts here, it comes down, it stabilizes, it comes down. So you have many opportunities to treat and hold it. So COVID, you don't. So, this is also application of our clinical knowledge to interpreting the pathology that you see and giving them feedback. Oh, if you're going to give them antifibrogenic, do it early rather than late. You may treat some patients unnecessarily. They may not have progressed, but others you will be helping if they've had severe COVID. So really interesting things to think about. Anyway, some things, when they occur, that it is connective tissue disease. For example, if you have rheumatoid nodules in the lung, which is rare. I mean, I've seen so many lung biopsies. It is really rare to actually find rheumatoid nodules. More commonly, what we find are this follicular bronchiolitis. This patient actually was only 15 years old. Kids also get rheumatoid arthritis and very severe rheumatoid arthritis, but you treat them well enough and early enough, they will not develop much fibrosis. SLE, they do develop interstitial lung disease as well as lupus pneumonitis, which we don't know very well. But anyway, you get an NSIP-like pattern. So NSIP is a very common finding in connective tissue diseases. In Sjogren's, the same thing. You get NSIP plus vascular involvement and other changes. So I actually have lost track of time. How am I doing for time? Okay. So to give you an example of what is a fibrotic NSIP, which can look like anything else, and a cellular. So it's the cellular NSIP that makes you think of, this patient was originally diagnosed as lymphoid interstitial pneumonia, but remember, LIP now is thought to be either a neoplastic process in adults if it presents, because they are all low-grade lymphomas, or the patient has an underlying immune deficiency, such as AIDS, or was born with a immune deficiency and combined SCID or combined immunodeficiency or something like that. So idiopathic lymphocytic interstitial pneumonia is really rare. So we don't really see that much anyway. But here is a comparison of how many lymphocytes you have as opposed to the fibrotic NSIP. And other diseases as well. So I'm not going to belabor the point too much, but any connective tissue disease can give you lung fibrosis and changes. You can get vascular changes as well. You can get pulmonary hypertension, and then you get fibrosis. The hypertension looks like anything else. By just looking at the vessels, you cannot tell them that this is connective tissue disease or not, but you can describe it and say, this is pulmonary hypertension, patient has NSIP. When you have both of those, it's much more likely to fit with it. All right, so now comparing the two head to head. As I said, clinical information is key, and you need to know all of that. You need to know the imaging. You need to know how severe was the disease. If it was a patient like me, I got COVID last month, by the way. Was home, got a stuffy nose, a cough. So if I was to come to you and I say, oh, I had COVID 2 months ago, would you be thinking I have COVID fibrosis? And I had some lung thing. You would not think that I had COVID fibrosis because it was not really severe. We think that the majority of patients who develop COVID have had severe COVID and were admitted for it, were on oxygen. But the picture is still evolving. People are saying that even those that got mild disease and were never hospitalized got enough injury that over the course of time, they are more likely to have pulmonary complications. So this is still an evolving field, and we will find out whether they are getting fibrosis. Are they more likely to develop or be more susceptible to other infections? Once you've had COVID, are you going to now be more susceptible to getting bacterial infection? Are you more susceptible to getting viral pneumonia? Flu, did everybody get vaccinated for flu? Yes, we should all get vaccinated. Things like that. So some things we really don't know yet, but some we do. So far, we think that severe COVID leads to pulmonary fibrosis. All right. So the things to remember when you are looking at a lung or you're thinking about this differential diagnosis is that if it is a UIP pattern, meaning those fibroblastic foci and the honeycombing, that is not how COVID looks. Nobody has described it. I haven't found it. It's not in the literature. People who've looked at these. Now, can a patient who has idiopathic fibrosis develop COVID and then die of it? Yes, of course. You can have any underlying disease. So you have to know what the patient has in order to interpret the pathology. All right. When you look at a section and the section looks really blue, meaning it has a lot of lymphocytes and plasma cells in it, it's going to be more likely to be a connective tissue disease. I kind of look at that. We talked about the NSIP pattern already, and then thrombosis and infarct. So NSIP by itself in patients who have connective tissue diseases tend not to cause infarcts or thrombi. Microthrombi, yes, but not larger ones. So if you have large vessel thrombosis, you should think COVID. All right. I've already mentioned UIP plus NSIP pattern. We've talked about IHC and ISH, and you've already got that. Okay, now in a patient like the one that I talked about, these patients with whatever connective tissue, they do have this stuttering course, and they will get exacerbations whether they have COVID or they don't have COVID. So you have to be careful. Just because you have a history of COVID doesn't mean that that fibrosis now is that. No, it's a balance. All right, so I'm going to end here, and this is the message that I have. I do have a, one of the things I do is when I travel or I take pictures, I always think about when I'm going to teach, what I'm going to say to people. So it brings your attention back. Oh, one of the things I also do is I like to teach about how to teach. And that may be one of the topics we can talk about. But my very first, now that I'm thinking about it, feedback on how I teach came from Dr. Chughtai. I was a fresh, but I think I was still probably a resident in pathology. And I had come back here, and he invited me to give a lecture at KE. I don't know if you remember it or not. It was a lymphoma or leukemia, something that was really not in my field. But I was a resident, I should know. And afterwards he said to me, he says, don't you think that was rather boring? Because it is true, we feel like we need to go through everything. You need to start here, describe this, and do that. And I still remember he says, you have to catch people's interest. You have to keep them engaged. You have to talk to people. So that I learned from you also, that you have to look at your audience. You need to look at, especially in the back. The people who are in the front are already always interested. But the back of the room, you got to engage people and say, I'm talking to you. You should listen. So lots of things. Anyway, so then I have learned some more things also since then. One of the things I've learned is that you have to tell a story and you have to correlate it. So this is actually the wall of the art. I love art. I go to the Art Institute all the time. And if you notice, the references, I'll give you a hint. This is a statues representing the 5 Great Lakes of the US. The Great Lakes, they're all connected. And when the fountain is running, the water falls from the Lake Superior, goes to the other one, and to all 5 lakes. It shows me and it tells us that we all work together. That what you learn, you learn by discussing from others, you learn from people, and you teach people by working with them. Not saying, here I am, I'm going to give you a lecture and you learn it. You have to have an interaction, and you have to keep people, you have to talk. While I have the podium, I can say a few things. You have to talk about things that your audience is interested in. You need to, if you're going to just give a talk, many trainees have to learn a lot of things, whether you are interested or not interested. That is one thing. There's a certain amount of coursework you have to do. But if you're going to give a talk somewhere, the lessons I've learned is first, assess who your audience is and talk about something that they see and they're interested in learning about. So when I sent the topic to Umar, originally it was because, I do a lot of lung. I love looking at lungs, and I do it every day. I look at lung and heart biopsies. But if you guys don't look at heart biopsies, there's no point in my coming in and talking about just interstitial lung disease. But COVID is something that all of us have experienced. And so that's what he said. It seems timely, it's interesting. So you have to know the interest of your audience. You also have to know what they already know and not just be talking at some level. And then you have to talk about something I know about. Just a book knowledge, I can give one of my professors once said, I can give a talk on anything. I'm thinking, but if you don't actually, if it's book knowledge, it's somebody else's knowledge. It's not something that you've worked out yourself. Because I find over the years, I have given lots of lectures that is not my area of expertise, and they have never been very successful. Because I don't know the subject. The examples I give you, all of these pictures I've taken. All of the patients I'm telling you are from my archive, even though my fellow is working on it. But they're so I kind of know what the story is, what I've learned, and that's what I'm trying to communicate to you. So I think you will be better teachers yourselves if you keep a few things in mind. And remember, pathologists are always teachers. You teach each other, you teach your clinicians, you teach your patients, and to learn not just how to be a pathologist, but to be a good teacher is really important. And for that, I thank you.